The chest wall program consists of a multidisciplinary group including different kinds of surgeons, both pediatric thoracic surgeons as well as pediatric cardiac surgeons. And we work together in a clinic that's staffed also with nurse practitioners and orthotists from our brace shop. In addition, we use the expertise from our orthopedic colleagues here in this hospital to help us treat a wide range of chest wall deformities, ranging from things as simple as pectus excavatum and pectus carinatum, but also things like June's syndrome or Poland syndrome or other syndromes where not only is there deformity, but where there's malformation of the chest wall or atresias of the chest wall.
A lot of times whenever they hit rapid growth, that's when it will start to develop more, because it's during that rapid growth phase that the bones and the ribs are starting to protrude or sink in more. And so at that point in time is when most pediatricians or family members will notice that there is an abnormality in the shape of the chest of the child. Occasionally we have patients who have decreased exercise tolerance and sometimes difficulty with breathing as well, such as asthma symptoms. Usually our patients don't have symptoms. The biggest complaint is that they don't like the appearance of their chest wall. When patients come to us and we diagnose them with pectus carinatum, or pigeon's chest, the one that sticks out, we send them to our orthotics department. For patients who have pectus carinatum that are no longer growing, so they've made it past the rapid growth spurts, those patients, their only option would be a surgical intervention. And that procedure is called a ravage procedure, and that's where you go in and actually remove the cartilage that's sticking out. And then you end up contouring the shape of the breastbone or sternum.
The surgeons, what they do is they use something called cryoablation, where they freeze the nerves to the chest wall temporarily, so they'll stay numb for about a month or so. But what we were finding was that didn't really kick in until about 24 to 48 hours after surgery, and the patients were not very comfortable during that first initial period. So what we did in anesthesia is we worked with many different techniques, and now we use something called a multimodal technique, where we give them both oral pain medications, non-opioid based, and we do something called a nerve block. We go adjacent to the spine, we put an ultrasound there, and we do something called a rector spinae plane block. So what that does is immediately after surgery, the nerves to the chest wall, they're numb, and so by the time the cryo kicks in, they experience very little to no pain afterwards. In fact, I'm proud to say that we were probably one of the first pioneers of this technique, working with our surgeons, and we're able to get patients out of the hospital in about a day or so with minimal opioid use versus 5 to 7 days in an ICU with an epidural, which was kind of what we were doing before and which is kind of the standard in most places. Most children are able to be off of all opioids by about a day or so. So it's very important for us.
In most institutions, specialists don't often work together very much on these things, and sometimes are in competition for this. But here at Shriners, we try very hard to work together. It's a much more collaborative environment, and kids get better care for that.
I have no doubt that they're going to get the best of care here at Shriners. No holds barred. We're going to take care of them like they were our own.
These programs are really the best ones you're going to find.